Hello everyone, and welcome to WEO's Colorectal Cancer Screenings Committee's first webinar of this series. Today's webinar is hosted by the expert working groups, New Tests, and Fit for Screening. Without further ado, I would like to hand over to Manon Spaander and Sally Benton, chairs of the Fit for Screening group.
Hi everyone, thanks very much Anka. So welcome, as Anka has said, to the first joint meeting of the Evaluation of New Test Working Group and Fit for Screening groups. So FIT, as everyone's aware, is pretty established in screening programs around the world and is being used in lots of different ways already. Thresholds can be altered to affect referral rates, and fecal hemoglobin concentrations are being considered in various risk stratification processes. In addition, there are constantly, and I'm sure all of you are aware of the constant stream of new tests that are being proposed to increase the sensitivity and specificity of FIT or to replace FIT as a triage tool for screening programs. And so as part of this, it's very important that we consider how new tests are introduced or evaluated first before being introduced into screening programs. So we made the decision as the chairs of the joint group. So we've got Graeme, Jun, Carlo, Senore, and Robert Bresalier, who chair the new tests group, and Manon and I as chairs of the Fit for Screening group, to combine for this single meeting of the combined groups to try and bring together the work we're both doing. So I thank in advance all our speakers. We've got a great agenda lined up for everyone, and I'll hand over to Manon to get the session started.
Yes, thank you, Sally, and really nice that I may introduce to you the first speaker, for which we're going to Australia, Graeme Young, having, I think, done tremendous work on writing the report on the consensus process of the guideline principles of evaluation of new tests. So, Graeme, the floor is yours.
Thank you very much, Manon. I'll just I've recorded my talk, so I'll just set this up for you now, hopefully.
So whilst Graeme's getting set up, just to add that we'll take questions right at the end, unless we have any time, but the plan is to take questions. So if everybody can make a note of your questions as the talks go on, we'll pick that up right at the end.
Yeah, unfortunately, as was happening before, I'm just losing control again. Try one more time. My apologies. Thank you for the opportunity to report on the deliberations of the expert working group on new test evaluation. My task today is to report on the principles that underlie the evaluation of new tests. In 2016, we published our recommendations that provided practical advice on how best to compare new with proven screening tests, the ideal context, the informative endpoints, and the appropriate study design. But much has changed since then. There have been substantial new developments in biomarker technologies. There has also been widespread implementation of organised population screening programs that makes test evaluation difficult in the intended to use populations. We can also see that there are differing goals of screening programs around the world as they adapt to the demands of the different healthcare systems. In addition, the evidence required by regulatory authorities and the processes that they follow differ between countries and differ from what healthcare providers wish to see and often from what professional guidelines include. Furthermore, there were omissions and some things need updating. For example, algorithm complexity and its associated challenges were not addressed. The biomarker section was very basic and did not allow for biomarker panels. And some of the things that now need adding to the guidelines have been presented previously at our April webinar. The 2016 recommendations were based on 8 guiding principles which arose from a consensus approach and a literature review. In planning this update, it was recognised that the guiding principles first warranted critical review. Thus, we agreed to undertake a review based on the Glaser and Delphi approaches to achieving consensus. The approach implemented was the same as previously undertaken, and we targeted an 80% agreement using a 5-grade scale on the principles. When initially considering the original 8 principles, we realised that one should be divided into 2 and an additional principle should be added. These are listed here. These were then subject to the consensus process, drawing upon the 47 experts from the World Endoscopy Organisation who had agreed to participate in this process. So far, 2 rounds have been undertaken, given excellent cooperation from the 47 experts. What I plan to do now is give you an overview of the consensus reached and then to address some of these in detail. In the first round, very good consensus was reached in 6 of the 10 principles, while 1 was marginal and 3 fell in the range of 74 to 79% consensus. Therefore, we reviewed the wording of those 4, but in addition, we realised that there were 2 other principles that should be added. These were then taken forward to the second round. As you can see here, given revision of the wording in the initial 10 principles, at least 84% consensus was achieved in each of these. In addition, we achieved almost 90% consensus in the 2 new principles. However, this does not mean that the wording is exactly correct, and there is now an ongoing process to further refine the wording and to reconsider these. What I now plan to do is to take you through some of these principles and to point to some of the issues that have emerged. A new principle that we introduced addressed what it was needed for a test to succeed. I do not provide all of the complete wording for ease of reading in these slides. What that principle said was that to succeed in programs and guidelines, application at key steps along the multi-step pathway of screening in an intended to use population is required. That reached 89% consensus. The points here were that simply having identified test accuracy would not be enough for guidelines and healthcare providers. This principle also overviews the endpoints that are informative, including engagement in screening, test failure rates, workloads for colonoscopy, determination of cost effectiveness, and surrogate measures for mortality benefits such as shift to earlier stage and for incidence. It's pointed out that comparative effectiveness randomised controlled trials are ideal for such purposes, and that some consideration needs to be given to longitudinal as well as cross-sectional data collection, such as would be required for repeated testing. Dialogue continues on what endpoints might be adequate. An emerging controversy is that whether or not earlier stage at diagnosis is enough to predict mortality benefit. Importantly, this principle was considered to be a high hurdle for regulatory approval as opposed to approval for guidelines. The process of test evaluation is costly, and one would like an early indication that the test would be worthwhile. Thus, it is recommended that the process of evaluation should follow a phased and sequential process, starting with moderate scale studies. The early studies might be cohort or case control studies, including subjects with and without neoplasia, perhaps enriched for neoplasia, especially cancer. Initial estimates of clinical performance characteristics and analytical specifications will be obtained at this time. If these results suggest that the test compares well with the desired standard, then evaluation should proceed to screening pathway evaluation requiring larger intended to use populations. The latter should be prospective. This achieved a high consensus. The concept was approved, but more detail has been requested. For example, when does the test threshold for positivity get set and can it be adjusted? There was also discussions about endpoints, and in particular, it pointed out that mortality benefit was beyond the scope of the test, as it was dependent on the medical practitioners for success. The next principle for discussion said that population RCTs with mortality and/or incidence reduction as the outcome set the expectations for performance of new tests. Efficacy of a new test may be predicted when compared to a reference standard, a comparator or index test, in a paired fashion, where the comparator's efficacy is supported by evidence. Initially, this did not reach consensus, but after revision of the statement, consensus was achieved. The main revisions made avoided the implication that guaiac tests set the standard and indeed would be a justified comparator. There was debate as to whether or not fit tests should be specified as the comparator, but as we know, there are many possible configurations of fit, and this needs to be worked through. There are also ongoing discussions about the role of multi-target stool DNA tests and indeed about colonoscopy as the reference standard. It almost goes without saying that a screening test defines likelihood for neoplasia. And so Principle 6 stated that in two-step screening based on first performing a non-invasive test, the test should identify those participants with an increased likelihood of neoplasia, who would then be expected to proceed to diagnostic verification. Initially, this was 81%, but scoring improved to 87% with adjustment. The adjustments included restructuring and simplification for clarity. Unfortunately, the original version was a principle for the screening pathway, which turned the focus away from test evaluation and to the actual diagnostic approach that should be undertaken. There was a controversial sentence indicating that a non-invasive test would not be expected to be as good as colonoscopy, and this was removed. While this is probably true, there are a few that would hope that the non-invasive test would one day be just as good. In working through the screening process, it became apparent that we had not been sufficiently explicit on what constituted a worthwhile target. Thus, we drafted a new statement which said this: for screening to be effective, it requires a non-invasive test in which the analytical target molecule, when detected, identifies an increased likelihood of relevant colorectal neoplasms. This achieved 91% consensus. It went on further to say that the goal of screening is to find curable cancer and/or to remove relevant pre-invasive lesions, that is, advanced adenomas and serrated lesions. But not all adenomas and serrated lesions need to be detected. Currently, we are most interested in those classed as advanced. However, the natural history of pre-invasive lesions is not well understood, and more research is needed to clarify how best to characterise those that are the most important to detect. It may eventually develop that biomarkers have a predictive capacity and indeed might provide the best characterisation of what constitutes a risky pre-invasive lesion. Explanatory text, which is going to accompany all of these principles, is going to point to the need to avoid overdiagnosis, because of the load on surveillance created by detection of less or unimportant lesions. The use of intermediate endpoints in the screening pathway can be useful in test evaluation. This principle states that performance can be assessed in parallel to an existing test of proven efficacy at any step in the screening process. But intermediate endpoints known to reliably and consistently predict potential for reducing mortality and/or incidence should definitely be used. We need the evidence base to support them. Such include estimates of test accuracy for cancer and precancer lesions, especially sensitivity and specificity, but also participation rates and shift to earlier stage. This statement achieved a consensus of 89%. This statement has been slightly refocused to point clearly to comparison of the new test with a reference standard at any step in the screening pathway. It also explains how intermediate measures could be used to guide the researcher as to its potential value. But there has been some controversy, and one of the issues is whether or not detection at an earlier stage of diagnosis is enough to predict in some way the mortality benefit. Note that eventually the mortality benefit is dependent on the practitioners who treat the lesions and not on the test itself. It is important to recognise that current evidence supporting screening tests depends either on detection of the bleeding phenotype or on structural detection of lesions. However, the biology of cancers detected by new biomarkers might be different. This principle states that non-invasive tests targeting new biomarkers might detect lesions with different biology and natural history from those detected by established tests. As a consequence, survival benefit might not be the same. Cancers might respond differently to treatment, regardless of stage. Pre-invasive lesions might have a different risk profile and natural history. It's important in such studies to explore concordance between the new test and the reference standard test, and this will clarify which lesions are newly detected, that is, not detected, say, by a fit test, and those which are missed. The value of treating lesions solely detected by the new test technologies should be determined. Are they unresponsive, of low risk of progression, indolent, or otherwise worth detecting? This failed to reach consensus in the first round, primarily because of clarity of the original wording. This was fixed, and a high consensus was ultimately achieved. An important principle added since the original recommendations was that a screening test with an adjustable threshold or algorithm for test positivity enables a program to choose the test accuracy parameters that best achieve desirable program outcomes. Originally, consensus on this was under 75%, but with adjustment went to 87%. An additional statement that we've included is that regulatory approval processes should recognise the capacity for adjustment of the positivity threshold when different performance characteristics are necessary to achieve screening program goals. Consensus was achieved by changing the word flexible to adjustable, but it is also noted that this view is going to be at variance with regulatory bodies in some countries. For example, in the USA, they have not approved an adjustable threshold quantitative fit test. Another principle states that it's not ethically justifiable to proceed to study a test in a typical intended to use population prospectively without studies that indicate that the new test seems to be at least as accurate as a proven comparator test. This statement also requires that the minimum standard should be that of a fit test. The crucial question is, what should that fit standard be, given that it's quantitative? We should note that US CMS guidelines about criteria for blood-based screening tests recommend at least 74% sensitivity for cancer and 90% specificity. These are not parameters that would be agreed to in other countries. However, feedback from the experts in this field pointed out that this needed much better wording, which has now been developed and is going to be subject to further discussion in the next few months. There is no time now to detail this, but there are international standards that can be applied. With excellent support from the expert panel, consensus has now been achieved on the 12 principles. At this stage, they remain open for comment, and fine-tuning of wording is yet to be completed with the panel. This may well take some months. Accompanying explanatory text will be provided in subsequent publication. An eventual publication of the deliberations of the expert working group are going to include additional materials presented as part of the webinars this year and possibly next year. Thank you.
Thank you so much, Graeme. You could unshare your screen. That would be brilliant. So that's a really great summary, Graeme. Thank you so much. That's such a difficult topic to cover in a talk, I think. So now we're going to head straight across to Carlo Senore in Italy. And Carlo is going to talk about what is a reasonable comparator test to run against for new tests. Thank you.
Okay, thank you, Sally. So just a moment for the, okay. Can you see my screen now?
Yeah, if you could put it
okay.
in slideshow. Yeah,
yeah. Thank you very much. Sorry, good morning, everyone, and thank you for the invitation in this meeting. I am discussing about the reasonable comparator test to run against new tests. I have no conflict of interest to declare. Well, as already mentioned in the guiding principle on 2016, GUAIC-FOBT was indicated as the minimum standard as a comparator test with a sensitivity for colorectal cancer ranging between 29 and 47%, and the specificity ranging between 87 and 98%. FIT was also indicated as an acceptable standard superior to GUAIC-FOBT. In the new revised version of the guiding principle, FIT is now indicated as the standard for comparator test. Randomized control trial documented an improved sensitivity for colorectal cancer and a better capacity to detect advanced adenomas for FIT as compared to GUAIC-FOBT. Observational studies have documented a lower interval cancer rate following negative FIT than following negative GUAIC-FOBT, and an increased detection of, in particular, of advanced adenomas following repeated testing with FIT. And preliminary report from population-based studies are suggestive for the effectiveness of FIT in reducing colorectal cancer incidence and mortality. The United States Preventive Services Task Force recommended that a one-off screening test should achieve at least a 70% sensitivity for cancer all stages and should achieve at least a 90% specificity. Desirable standards have not been set for advanced adenomas. According to a recent review of several studies, FIT, when used at a cutoff of 20 micrograms of hemoglobin per gram of feces, can achieve such standards. The sensitivity for colorectal cancer was set at 75% and the specificity was 95%. But we have several different FIT systems in the market. They are using qualitative and quantitative method. They are using variable number of samples, even if most programs now require a single sample. And there is a variability in the choice of the positivity cutoff. And as long as the accuracy of the test is influenced by the characteristics, by the cutoff and by the protocol, the interval and the number of samples, when using the FIT as a comparator, we need to set a standard. And one recommendation could include the recommendation to use a quantitative fit method performed over a single sample. When considered the positivity cutoff, available evidence is suggesting that different quantitative methods are showing different performance characteristics. This recent comparison of sensitivity and specificity for advanced neoplasia of 9 quantitative fit has indicated that there was a large variation in the sensitivity and specificity when using the threshold recommended by the manufacturer. This variability was reduced in particular for specificity when using a uniform positivity cutoff, and it was minimized when using a threshold adjusted to yield the same specificity for all tests. But the evidence from a comparative study conducted within ongoing organized screening programs provided sound reasons for recommending comparing fit method performance at identical positivity rates. As Graeme was already mentioning, a new guiding principle was introduced with the recent consensus revision related to the adjustable characteristic of the threshold. A screen test with an adjustable threshold for test positivity enables a program to choose the test accuracy parameters that best achieve the desired program outcomes. This has implication for fit, as ideally the positivity threshold should be low in comparative studies, in particular stipulating colonoscopy follow-up only for subject testing positive at either test, to allow simulating comparison at different cutoff level and decreasing positivity rates. And the new test cutoff needs to be flexible, and this performance should be measured simulating different cutoff levels, focusing on the positivity range of established population-based programs. We can start at an early phase of the evaluation process paired comparison, head-to-head comparison of the new test and the standard comparator test, implementing study using a paired design within ongoing screening programs. We can assess the relative sensitivity and relative specificity of the new test in the context in the population where the new test is intended to be used. We will send for immediate assessment for with colonoscopy or subjects who are positive the comparator test, and all those testing positive with the new test. Participants in the panel recognized the importance of having a prospective evaluation, but concerns have been raised about the feasibility of such evaluation. Requiring a new test to be tested for multiple rounds is ideal, but it seems a very high standard. And the test needs to be introduced into the market, and then the subsequent evaluation needs to be done. These were some of the comments we received in the consensus process. However, prospective evaluation is providing crucial information about test performance. The detection of early stage lesion is a goal, and therefore stage shift of screen detected lesions may be considered as a plausible surrogate measure, but screening may also increase the detection of indolent lesions. So the change in the absolute risk of late stage diagnosis would seem a more valid measure than a stage shift. The new test, apart from detecting new lesions compared to the reference, might miss lesions detected by the reference test. And so to assess the clinical significance of the discordant cases, a prospective comparative evaluation should still be necessary. Here is an example of a comparative prospective evaluation of the fit test in the context of ongoing screening program in Italy. Following the introduction of fit screening, the incidence of stage 1 cancer was substantially increased over 4 times among people attending the first screening episode as compared to people who had not been invited. The increase was also observed for stage 2 and 3 cancer, and that was a decrease in stage 4 cancer. But so there was a stage shift screen detected cancer. At subsequent round among people with a previous negative test, we still observed an increase in the incidence of stage 1 cancer among people attending screening as compared to non-invited, but the detection rate, the incidence of late stage cancer, stage 2 and 3, and even more stage 4, was substantially decreased. Also, if the test is detecting progressive lesions, we can expect that the incidence of cancer following a negative screen test would be reduced. And this was in fact already, this trend was already documented in these comparative studies of FIT and WEO, which indicated that the higher incidence, higher detection rate of cancer with FIT as compared to WEO at screening was associated with a lower incidence of interval cancer rate following a negative FIT test as compared to the incidence of colorectal cancer following a negative WEO test. And as long as the test need to be repeated, we need to get a prospective information supporting the decision about the optimal screening interval. And this information can be derived assessing the time trends of interval cancer rate. To try to reconcile the requirement of the regulatory authorities and of screening programs, it has been proposed by some participants in the consensus process to have a separate step in the approval process for prospective evaluation. The test could be approved for individual use after a head-to-head comparison and for use in organized program after rigorous cost-effectiveness evaluation over multiple rounds. However, as long as issues addressing the prospective evaluation are relevant also to individual use, this approach might not be satisfactory. Another question raised during the consensus process was related to the utilization of FIT as a standard for all comparative evaluation of new tests. The question was raised for the comparison between FIT and blood markers, but this comparison is already applied in several studies. The question is also relevant when considering new imaging methods like CT colonography or colon capsule endoscopy, which are under evaluation for introduction in the context of ongoing screening programs. This test would be offered longer intervals, and therefore the possibility to use sigmoidoscopy as a comparator, as indicated in 2016 guiding principle, might be considered, in particular because these tests are aimed to the detection of pre-invasive lesions. And finally, some words about the context for comparative evaluation. Organized screening programs represent indeed an ideal platform to implement this multi-phase evaluation process of a new test. The framework for learning programs adopting a randomized design to assess the effectiveness of changes within ongoing establishing program following the introduction of changes in the protocol might facilitate a comparative assessment. And also the implementation, whenever feasible, of biobanking within existing programs should be considered, as it would allow to set up studies aimed to assess the markers, the role of markers of risk of progression of the lesions detected by different tests. Thank you very much for your attention.
Thank you, Carlo, for this very nice presentation. I think an interesting topic for debate maybe later on, and also a challenging topic on how to deal with the comparative test for the daily practice when you're trying to set up a new test. And maybe it's a little bridge to the next speaker of this webinar. It's actually two speakers from the Netherlands, Beatriz Carvalho and Veerle Coupé. They did a study and they will show how they validate a new test in CRC screening. So Beatriz, I think the floor is yours first.
Thank you. I will share my screen now. Let me put in the presentation modus. Can you see it now?
Yes, we can see it. Thank you.
Okay. Now, thank you for the introduction. And indeed, we're going to show how we did it. And in fact, we're going to show how we try to do the development of a multi-target fecal immunochemical test, or MT-FIT, for colorectal cancer screening. And although today Veerle and I are presenting this work, this is really a big teamwork and with a big collaboration between these three institutions, the Netherlands Cancer Institute in Amsterdam, the Amsterdam UMC and the Erasmus UMC. Well, as it was already mentioned, FIT is being used as a test for several screening programs in the world, and also is the case in the Netherlands. And here depicted in this scheme, you see the logistics of the Dutch National Colorectal Cancer Screening Program. So what we do in the Netherlands is that people with the age between 55 and 75 get an invitation in the mailbox containing a FIT test, and then they collect the stool sample, they send the package to the laboratory that will be analyzed, and then if it's a negative test, then these people will be again invited in 2 years later. But if the test is positive, then these people will be invited to go for further research and undergo colonoscopy. This is a volume of more or less 1.6 million participants per year in the Netherlands. And this has been so far a big success. So it works, this screening program. And as it was already mentioned by the previous speakers, we observed already in 2018, I must say that the screening program started in 2014. And in 2018, you can see here a graph showing the shift of staging when you do screening. So when there are symptoms detected, so no screenings, then you see that the majority of cancers detected are late stages. And with the screening, you see the shift to earlier stages, stages 1 and 2. So it looks like it's working, because that will have, in principle, impact in reduction of cancer mortality, which is the goal of screening. However, we know also that there is still room for improvement, because we know that the FIT performance, it's reasonable, but it's not perfect. So it has a higher specificity, around 94%, and a reasonable sensitivity for detecting colorectal cancers, around 80%. Still, the sensitivity to detect advanced precursor lesions is quite poor, around 27%. So taking that in mind, we aim to develop a new cost-effective non-invasive screening test that would be suitable for programmatic screening. And so like in the Netherlands is the case. So in our specific case, we want to have a protein assay that will be optimal for early detection of advanced neoplasia in stool. And here I would like to bring the context of the recommendations for evaluations of new tests, the ones that are published. So the revised ones we will hope to see in the coming months coming up. But for now, I will come back to these different phases of evaluation of new tests and along the talk while I'm presenting the work we did. And here is a scheme of the overview of all the steps we did so far to develop our protein assay test. And we started this effort in 2015, first starting with a discovery phase. And how we did it, we started with a whole stool sample collections from colorectal cancers and controls. And we isolated the proteins from these stool samples, and we analyzed them by means of mass spectrometry. We did first this series, and we looked for enriched proteins in the cases compared to controls. And then we subsequently did an independent validation on the different sample series, so independent series, this time containing not only colorectal cancers and controls, but also precursor lesions, including advanced adenomas. We did again the same. We isolated from whole stool samples the proteins, and we measured them by mass spectrometry. And when we combined, we managed to validate 10 proteins that were significantly enriched in colorectal cancers and advanced adenomas compared to controls. So then the next step is to validate, make a retrospective validation. And this is what is also recommended in the recommendations guidelines. So how did we do this? Well, we had one challenge that we wanted to get away from, was that we did our discovery phase using whole stool samples, but this is not really compatible with our Dutch system using a mailbox. And on the other hand, we did also in the discovery a very expensive technique, mass spectrometry, that we also not really compatible for programmatic screening. So in that, we did two different steps. First, we reduced the stool to be analyzed. So we started to look at minute stool amounts on leftovers FIT samples. And on the other hand, we took the step to develop an antibody-based assay to be more compatible with the programmatic screening. And we did this this validation using these two new steps on the 10 proteins that we discovered previously, and we did this in more than 1,200 FIT samples. And indeed, this validation worked out. So from the 10 proteins, one assay unfortunately failed, so we didn't proceed with that one. But from the other 9 proteins, the 9 assays were successful, and we could validate that these proteins were significantly higher expressed in colorectal cancers compared to controls. And 8 of 9 of these proteins were also significantly higher expressed in advanced adenomas compared to controls. And at this time, I will pass my word to Veerle, that will continue how we continue to go to an assay, a panel assay. Veerle, the floor is yours.
Thank you very much, Beatriz. So to build a classifier from these 9 proteins, a classifier that is able to distinguish the individuals with advanced neoplasia, there were 212, from those without colorectal neoplasia, which were 769 individuals, we used classification and regression tree analysis, in brief called CART. And this method is a non-parametric regression method that on the one hand allows for capturing nonlinear effects of covariates and simultaneously interactions between covariates. And this algorithm identified both the optimal combination of complementing protein biomarkers, and it also yielded the optimal cutoff for these proteins. As you can see in the tree, the CART analysis yielded a combination of hemoglobin, calprotectin, and SERPINEF2 to have the best diagnostic performance. Individuals with high hemoglobin levels, higher than 20, were classified as advanced neoplasia cases, while those with very low levels of hemoglobin, below 1.3 microgram per gram, were classified as controls. And in between those two hemoglobin levels, the markers calprotectin and SERPINEF2 were used for further refinement. Next slide, please. As an internal validation, we carried out a leave one out cross-validation procedure. In this procedure, we kept the specificity of the multi-target fit at 96.6%. This was the same as when it was when we trained the CART model. Furthermore, we set the cutoff of the fit test such that the same specificity was obtained. Then the cross-validation procedure resulted in a cross-validated estimate for the sensitivity of the multi-target fit, which can be directly compared to the fit sensitivity. Overall, that's actually not indicated on the slide. Overall, we found a sensitivity for advanced neoplasia of 43% for the multi-target fit versus 37% for the fit. And this difference was completely due to a difference in the sensitivity for advanced adenoma. And this you can see in the left panel on the slide with a sensitivity of 38% for the MT fit compared to 28% for the fit. And this is a significant difference. Sensitivities for colorectal cancer, shown in the right panel, were comparable. Something that's not shown here, but that's worthy of note nevertheless, is that the sensitivities for advanced serrated lesions were equal for both tests, and they were 10%. Next slide, please. To further investigate the potential of this MT-FIT test for screening and whether this would improve the current fit-based program or could improve the current fit-based program, we carried out an exploratory analysis with the Dutch ASCA screening model. ASCA stands for Adenoma and Serrated Pathway to Colorectal Cancer Screening Model. And in this exploratory analysis, we simulated a cohort of 20 million people. These people start in the model at age 20, and we follow them until they are 90 years old or die. whichever comes first. First, we simulated a cohort without screening. Then we simulated a cohort again, but now assuming that this cohort is screened according to the Dutch population-based screening program. This means that individuals between the ages of 55 to 75 are invited to FIT screening every 2 years. The participation rate is 73%, and people with a positive test are referred to colonoscopy. 92% of people who are referred actually undergo colonoscopy. And then finally, we simulate the same screening strategy, but now assuming that the multi-target FIT is used instead. Because both tests are stool tests, we assume that participation rate to screening and to colonoscopy is the same, whether you use FIT or multi-target FIT. Next slide, please. Based on our model simulations, we found that the improved detection of advanced adenomas of the MT-FIT would impact long-term CRC incidence and mortality. And the projected reduction in CRC incidence compared to FIT screening was 12%, and the projected reduction in mortality was 8%. And this equals a reduction of 6.5 CRC cases and 1.3 CRC deaths in the lifetime of 1,000 individuals. We also looked at whether the MT-FIT can be implemented in a cost-effective manner compared to FIT. And we did this by stepwise varying the costs of the test until the additional cost per life year gained fell below the Dutch willingness to pay threshold. This latter number is 40,000 euro per life year or per QALY, which corresponds to the WHO recommended threshold. And we found that the maximum cost for the MT-FIT to remain below this cost effectiveness threshold was 59 euros. Just for comparison, the cost of the FIT an hour in the Dutch program was set at 23 euro, which includes analysis and programmatic costs. Next slide, please.
So here I will come back again. So after these promising results, we then proceed to the next step to try to do a prospective evaluation. So now we are in the phase of preparing a screening trial within the context of the Dutch screening program. So following the guidelines phase 2 and phase 3. So how is the study going to look like? So we made a power calculation that we needed to invite 13,300 participants of the Dutch screening program. And we will follow more or less the logistics of the screening. So people will invite it via the mailbox to participate in the study. If they agree to participate, then they will receive later on a package, not only with the standard FIT, but also with a second FIT tube, so that they can perform also the MT-FIT. Then they send the two tubes to the laboratory. The analysis will be performed like in the screening. And if both tests are negative, then they will get invited again in the next 2 years. And if one of the two tests is positive, then they will get again a referral for colonoscopy. And here is just a scheme to show you that this is a complex process with different parties playing a role. So not only involving the participant, of course, that is the main center of our study, but the screening organizations, which will perform with invitations. The participant will give or not the informed consent to the founders. So the Netherlands Cancer Institute will receive that and communicate back to the screening organizations. Then participant will receive the package, send it to the laboratory. The FIT results will be directly sent to the screening organization, and the MT-FIT will be sent to the Netherlands Cancer Institute, where the algorithm will be performed and send the final result to the screening, which will at the end report to the participant the end result. So this is just to have an idea how this data flow is quite complex, and we are trying to do as much automatic as possible. And here is the time planning of our prospective study. So we are here today. The batch production for the 13,300 participants is being in the final phase of preparation. So we intend to start the assay verification in our hands at the laboratory in December this year. Then still in December, we will have to make a chain verification to see that everything is working. And then we can start, in principle, in the beginning of 2022, our prospective study. We will start in a small, with a small pilot first to evaluate the volume of invitations we have to do at the time and to check last details on the chain. And then we can start with a big volume of invitations from March on. And this will implicate that in the fall, so in October, all the inclusions will be completed. And then, of course, we have to wait for the positive people to still undergo colonoscopy and wait for the results. So the prediction is that in March 2023, the study will be complete. And I would like to end with our presentation with the translational research roadmap to show that we did all the steps and we are approaching now the end of the road. So we did identification, marker discovery, we validated, we did assay development, we did some exploratory cost effectiveness analysis, and now we are at a full speed to start the prospective trial in the beginning of next year. And this, of course, is the work of many, many people. I would like to thank first the PhD students that not only did the analysis of the retrospective validation, but are also responsible for preparing the prospective study, the supervisor team, Mike de Witt, Gerrit Meijer, Evelyn Dekker, and Manon Spaander, the laboratory that is going to perform all the analysis. And of course, this will not be possible without the collaboration and participation and thinking along of Freya Meyer from the screening organization and Iris Rizis from EDVN. And of course, all the funders that are accompanying this long process since 2015. Thank you for your attention.
Thank you so much, Beatriz and Veerle. I love that talk. I love that project. I think it's absolutely amazing. So moving, we're going to move on to the next speaker now, but can I just encourage people to put questions in the Q&A? Oh, I can see there's some coming up now. Nope, that's in the panelist box. Yeah, please can I encourage people to put questions in the Q&A box so we can pick those up at the end of the meeting and the discussion. So moving on now to the next speaker, we've got Hermann Brenner from Germany, who's going to talk about more efficient use of FIT and colonoscopy in colorectal cancer screening, the gate opener approach. So over to you, Hermann. Thank you.
Hello, I hope everybody can see the screen now. First of all, thank you very much for giving me the opportunity to share with you something that is slightly different in the scope compared to the previous talks, but nevertheless quite closely related to FIT-based screening. We are trying to share with you a first proposal of more efficient use of FIT and colonoscopy in colorectal cancer screening, an approach that we called the gate opener approach. To first attempt to, in very simple way, explain what this is all about. When we look at the established screening methods, we have, of course, the FIT-based screening, which is offered as a biannual screening in most, at least European countries where it's offered. And here is just as an exemplary presentation with about 50% participation of those who are invited, 10% positives, and 80% of those who are positive that would follow, then up by colonoscopy. These are just exemplary values. One could simply take also different values, but at the end, this means that approximately 50% are screened every 2 years, and approximately 4% would finally go at colonoscopy. With these numbers, we know that, of course, this varies a lot. For example, in the Netherlands, there are, of course, higher participation rates. In other countries, there are lower participation rates, but these numbers actually are, as I said, simply exemplary and do not really matter. What I want to focus on is actually the contrast to other approaches. There are approaches to do screening by colonoscopy, which usually means an offer every 10 years to go to colonoscopy. There, the participation rates are usually much lower. For example, in Germany, where screening colonoscopy is offered since 2002, we have on average approximately 20% or even less participation rates within these a 10-year time window. Now, what comes in is this gate opener approach that would work or try to combine the benefits of both established approaches and in the following way. We would use a FIT, but only every 10 years to invite people to go to screening. But this FIT would then not be interpreted in a conventional manner, but it would the positivity threshold would be adjusted in such a way that 50% of those participating would be classified as positive, the others as negative. With such a FIT approach, we would expect that approximately 50% or at least the same percentage of people would go to FIT as in a FIT-based program, but then with this low positivity threshold, a large proportion of those who go to the screening would then also go to colonoscopy, and at the end it would probably be approximately as many people going to colonoscopy as in the colonoscopy-based screening. But since these people would be pre-selected by this quantitative FIT, we would of course expect that overall the detection rate of relevant neoplasms would be much higher than in the colonoscopy-based screening. So a simple summary of the approach. One would start with a single FIT every 10 years. The positivity threshold adjusted to yield 50% positivity, and only those people would then encouraged to go on to colonoscopies. The others would not be forbidden to do a colonoscopy, but not really be encouraged to do so. We would expect that in the first place, we have a much higher participation rate in the FIT as we see in the FIT-based programs. We would also expect that at the end, we'll have at least the same, if not a bigger participation rate in colonoscopy. By this pre-selection through the FIT, we would expect a much higher detection rate of relevant lesions, and by combination of these factors, at the end expect higher effectiveness. Of course, we do not want to stay with simple beliefs of what would happen. We also did first analysis by modeling on the expected effectiveness using our COSIMO. This is a colorectal cancer multi-stage simulation model that we have developed over the past years and validated. It's fully transparently published, and so everybody in principle could use this model. Then we modeled quite a number of scenarios in a short time we have here. I can show you just two of these scenarios. For the traditional conventional screening colonoscopy, we assumed an uptake rate of 20%, approximately the number we have here in Germany. For the gate opener approach, we assumed, or did a first scenario assuming a 50% uptake of this gate opener FIT with 50% positivity rate, and then 25% would be encouraged to go to colonoscopy, and with 80% colonoscopy uptake, again 20% at the end would go to a colonoscopy. And then we did a second scenario where we assumed a higher uptake rate of the initial gate opener FIT, and correspondingly a higher colonoscopy rates at the end. So let's come to the results of the modeling. The first slide here looks at the expected detection rates of colorectal cancer at the follow-up colonoscopy, comparing the gate opener approach, the red columns, with the conventional colonoscopy-based screening. And as you can see here, we would expect approximately a double detection rates in this scenario. But you also see in green the columns for those who would actually be prevented from colonoscopy compared to a traditional colonoscopy-based screening approach, which shows that it's really not very meaningful for those with these very low fit values to go to colonoscopy. Then the next outcome we looked at was the expected impact on the number of prevented colorectal cancer cases, again comparing gate opener with a conventional colonoscopy-based approach. And here we would see that even if in a conservative model, we assume that at the end we have the same colonoscopy uptake rates in both approaches, the gate opener approach would be expected to prevent approximately 50% more CRC cases within 10 years. When we look at the prevented CRC deaths, the difference would be even larger. Here we would expect 60 to 70% more prevented CRC deaths with the gate opener approach compared to the conventional screening colonoscopy approach. But this is, as said, for the conservative assumption that we overall reach the same colonoscopy uptake rates. If we go to the other scenario, where we assume that at the end 30% rather than 20% would go to colonoscopy with a gate opener approach, the differences are much larger. Here we would expect more than 125% more prevented CRC cases within 10 years with the gate opener approach compared to the conventional screening colonoscopy approach. And looking at CRC deaths, the difference would be even larger, with close to 150% more prevented CRC deaths within 10 years for the gate opener approach. With that, I'm coming to the summary. Compared to the decennial colonoscopy-based screening, the gate opener approach should enable more efficient use of colonoscopies with an approximately doubled CRC detection rate, depending on the different assumptions, somewhere between 50 and 150% more prevented CRC cases or CRC deaths. Compared to the annual or biennial fit-based screening, I did not show model calculations for that yet, but it's relatively clear that, of course, one would have to do up to 90% or up to 80% less fits. And of course, one would have the possibility to detect more adenomas, especially advanced adenomas, and to prevent more cancers, because the fits have, we've also seen in previous presentations, relatively low sensitivity for those. Of course, there's need for further research. There's for sure need for more comprehensive modeling studies, which we are currently doing, and which we would encourage to be done by others. And then, of course, it would be a next step would be the empirical evaluation in a model project. Our vision with this approach is to bring together the benefits of two so far essentially distinct approaches to colorectal cancer screening, the fit-based screening and the colonoscopy-based screening, both of which have their big advantages, but they also have their bottlenecks. For fit-based screening, it's the low detection rate of the precursor lesions, and of course the need to repeat this so often. For colonoscopy-based screening, it's the essentially a low uptake rate in the first place, and the invasive nature, the high need of capacities, and also the fact that we are doing so many unnecessary colonoscopies in those who are really at low risk. So with the gate opener screening, we would like to take advantage of the benefits of both, trying to avoid some of the bottlenecks and hopefully have a chance to do more effective colorectal cancer screening in the future. And with this, I would like to end and thank you very much for your attention.
Thank you, Hermann, for this very, very nice presentation. And combining actually the FIT screening and colonoscopy screening for colorectal cancer. Really nice model study. I think also a topic really open for discussion on this. And I saw also in the panelists that Graeme is having some questions, but that we go on for later in the discussion part. So if you have any questions, just use the Q&A box and put in your questions, and then we will address it at the end of the session. But first we go to our last speaker from Hong Kong, Dr. Jun Yu, who will going to talk about the gut microbiome as biomarker for colorectal cancer and adenoma.
Can you see my screen?
Yeah, you just have to put it on, yes, and present the slide.
Okay, thank you.
Thank you.
Okay, thanks for Chairman for the introduction. And good morning, ladies and gentlemen. It's my great pleasure and honor to share with you a topic on gut microbiome biomarker for colorectal cancer and adenoma. Actually, the role of microbiome in colorectal cancer biology has been increasingly recognized. Based on the shotgun metagenomic sequencing, and studies have characterized the fecal microbiome dysbiosis of CRC adenoma patients as compared to healthy individuals, and which is suggesting the possibility of microbiome dysbiosis as a biomarker for colorectal cancer and adenoma. I would like to discuss the fecal microbiome biomarkers, including bacteria and non-bacterial biomarkers. Let's first start from bacterial biomarkers. And based on the shotgun metagenomic sequencing analysis of stool samples, and from this heat map, you can recognize the differential bacterial abundance between CRC patients as compared with the healthy controls. We identified the 20 stool CRC bacterial gene markers. And from this picture, you can recognize that the red color is the CRC patients, and these 20 gene markers can distinguish the CRC patients as compared with the healthy controls. And these markers are different, are independent of type 2 diabetes and inflammatory bowel disease. And then using a quantitative PCR analysis, we compare the performance of the different enriched bacteria with demonstrating that the fusobacterial nucleatom quantification as a useful biomarker for detecting CRC and adenoma. The performance, and this single bacterium is competitive to the performance of 4 bacterial combination and for the detection of CRC. And this we compare with FIT, and then these fecal bacterial markers significantly improve the detection sensitivity and specificity, especially for stage 1 and stage 2 CRC patients compared to FIT. So the combined bacterial marker with FIT have a significantly improved performance with both sensitivity and specificity over 90%. In addition to service as a diagnosis biomarker in stool samples, and this fusobacterial nucleatom was also reported from Dr. Ochino's group, and he demonstrating that the bacterial DNA in colorectal tissue biopsy is associated with the shorter survival, which may serve as a prognostic biomarker. And we have recently demonstrated that fecal lectinal Clostridium M3 markers have a good performance for the detection of advanced adenoma. Okay, and with a further comparison in different cohorts of stool samples, we demonstrated that fusobacterial nuclear atom is a promising biomarker for colorectal cancer, and the M3 is good for the detection of adenoma. Of course, the F1, the fusonuclear bacterial atom, have also have some detection performance in terms of the advanced adenoma and also adenoma as well. We signed a license agreement in a Hong Kong company, and this company established the detection kit, and which has been applied in clinical practice or clinical detection for colorectal cancer and adenoma as a non-invasive bacterial DNA marker, a bacterial gene marker, and also this marker also applied in nearby countries. And this is about bacterial marker and based on the shotgun metagenome sequencing and in stool samples from CRC patients, adenoma patients, as compared with the healthy subjects. And then we also studied the fungal biomarkers. And also the human gut, we know that a human gut have a complex ecosystem of bacteria, fungi, archaea, and the virus. In addition to bacteria, we have also investigated the contribution of non-bacterial microbiome in CRC adenoma and their potential utility as a biomarker from stool samples. And this fecal shotgun metagenome sequencing was performed in different populations, which including 2 Chinese cohorts, and also this biomarker identified from the virome, also identified for fungi, also validated independent cohort of published repository sequence from French and Germany. And this is the cohort information in terms of the shotgun metagenome sequencing data. We compare the fungal composition in our cohorts, both unsupervised and supervised ordination analysis, identified that the gut fungi discriminate CRC and the control into 2 distinct groups, indicating that the gut fungi dysbiosis in CRC. Fungi components form the different clusters from control early stage CRC and later stage CRC, and suggesting a CRC stage specific disruption in fungal homeostasis. And from this heat map, we can see the differential abundance or enrichment in terms of the fecal fungi in CRC patients versus control. And the abundance of 14 fungi biomarkers can significantly distinguish CRC from control subjects. And these 14 fungal markers classify the CRC and the controls with an AUC of 0.93. And they also distinguish the control from early stage CRC with an AUC of 0.91. The performance of the fungal markers was confirmed in an independent Chinese cohort with an AUC of 0.82 for CRC and an AUC of 0.81 for early stage CRC as compared to healthy subjects, respectively. And moreover, these fungal markers were further validated in German and French population, and with an AUC of 0.73 for CRC versus control, and AUC of 0.71 and for early stage CRC versus control, and respectively. Let's move on to the viral biomarkers. We studied the viral and taxonomic components of CRC in multiple cohorts, including 2 cohorts from Chinese and other cohorts from Austria, French, Germany. We analyzed the virome, also called bacteriophage, of fecal samples from colorectal cancer patients, adenoma patients, and healthy individuals in these multiple cohorts. And then the diversity of the gut virome community was significantly increased in patients with CRC compared with the controls. However, the diversity of bacterial community was significantly decreased in CRC patients as compared with the controls. There is a negative association between bacteria and viral diversities was detected only in a control group, and this negative association was not identified in CRC patients. And after adjusting for potential confounding factors, we demonstrated that the clinical stage associated dysbiosis of the gut virome in CRC. And from this picture, you can recognize that a significant separation of controls, early stage CRC and later stage CRC, and yeah, it's clearly identified. The differential abundance of gut virome was demonstrated, and yeah, based on this figure, we can see the different composition or the abundance of virome in CRC patients as compared with the controls. So there's 22 virome taxons were found to discriminate CRC patients from controls in the discovery cohort in Hong Kong Chinese, and also in 3 independent validation cohort from the second Chinese cohort in Hong Kong, and Austria, and French, and Germany. In addition to the diagnosis performance of these stool viral markers, we also demonstrating that combination of 4 viral markers as indicated in the red curve is associated with reduced survival of patients with CRC. And these viral prognostic biomarkers are independent of other confounding factors as shown in this picture. So this survival viral biomarker are independent prognostic biomarker for CRC patients. Let's move on to the last potential microbial biomarker, archaea. Compared to other bacteria, viral or fungi, the patient with CRC, it's already shown that have a clear different gut microbial signature for bacteria, fungi, and the virus. However, it's little is known about the archaea components in CRC and the controls. Evaluation on gut archaea showed the distinct cluster for CRC patients, adenoma patients, and control subjects as well, suggesting a compositional alteration of gut archaea in colon tumorigenesis. Especially, you can see in the panel C, you can see an increasing change from control early CRC and advanced CRC in control adenoma and the CRC, and there is a trend. This is one of the examples. There are quite several of these candidates. Archaea, there is a trend and the shift and between the from the disease progression from control adenoma and CRC. We further investigated the relationship between differently abundant archaea and the bacteria and identified the positive correlation between bacteria and archaea diversities in control subjects. However, this phenotype was not observed in CRC patients. And this result suggests that the cooperation between commensal archaea and the bacteria in healthy subjects is lost in CRC patients. We identified the differently abundant of archaea species in CRC patients compared to healthy subjects. The non-enriched archaea species could distinguish CRC patients from control subjects with an AUC of 0.82 in the discovery cohort and 0.83 in the validation cohort. And based on this investigation, microbial biomarker from bacteria, fungi, virus, and archaea, we will further perform integrative analysis of fecal microbial biomarkers using machine learning so as to form a best panel of stool microbial biomarkers for the detection of CRC patients with more optimizing sensitivity and specificity. Ladies and gentlemen, I would like to make a conclusion that, based on this a fecal microbiome biomarker study. And yeah, the number one, the gut microbiome is a key environmental factor influencing the colon tumorigenesis. Bacterial gene markers have been applied for clinical detection of adenoma and CRC patients. The dysbiosis of other non-bacterial microbes like virum, fungi, and archaea can be potential biomarkers for colorectal cancer patients and also the adenoma patients. The BISA panel of microbial biomarkers is worth further investigation and confirmation. I would like to thank Professor Joseph Song and for the long-term guidance and supervision for our research project on microbiome in colorectal cancer and also other GI cancer disease. And thanks my colleagues and the students and for their particular contribution and hard working and to the individual investigations. Thank you very much for your attention. Thank you.
Thank you so much, Jun Yu, for an amazing talk. And thank you to all our speakers. They're always such a high quality of talks that we get in this meeting. And makes me think so much about all the potential work that we can do and everything great that's going on. So Manon and I are going to just run through the questions. So thanks very much to all our speakers for keeping to time. We are 2 minutes ahead of schedule, which is always a positive. So just picking up some of the questions from the Q&A. The first one is from Tatiana Koffel. And this is to Veerle and Beatriz. Are you able to predict the price range of the new tests which you will be testing if it will be produced for massive use?
Maybe I can start answering. Well, the test that we are now using for the prospective study, it's not yet a test to be implemented because it's still an expensive technology. But of course, what we are dealing here is with 3 proteins instead of 1, like the FIT. So our expectation is that the final test that could be implemented in clinic would be a FIT plus 2 other ones. So it's a very similar technology. So we expect the price to be a little bit more expensive than FIT, but not much more higher. And as Veerle showed, we can go up to 59 euros a test and still be cost effective. I don't know if Veerle wants to add anything.
I don't think I need to add to that. We indeed looked at the maximum costs and we have discussed whether this was realistic, something that could be achieved and that justified going on to prospective validation, which we deemed feasible.
Thank you. Then also the next question, also for Beatriz and Veerle, is from Stephen Halloran. And besides complimenting you with the excellent presentations, he wants to ask, with the increased colorectal cancer adenoma sensitivity observed in alternative markers, have you investigated the likely reason for this increased sensitivity in these markers? And if so, does it point to fecal markers characteristics we should be looking for in new markers? Is this one for Beatriz or for you, Veerle?
I think that's a very good question. And when we look at the present markers in this panel, and that I will also, I think, tackle the question of Graeme, they are, well, we have the hemoglobin, so it's the same as the FIT, looking for blood. And we have calprotectin, that is an inflammation-associated protein. And we have SERPINF2, that is a protease inhibitor and a serine protease inhibitor, and it has a role in remodeling the microenvironment. So these 3 proteins, they are still not really tumor specific or epithelial specific, although we don't really know because these are never black and white functions, but they could play a role in the microenvironment of the tumors and so the stroma. And the reason why are they detecting better advanced adenomas, that's a good question, because we assume that adenomas don't have so much stroma as cancers. But the fact is that indeed there is more chances they are complementing a little bit what hemoglobin is failing, maybe inflammation factors or remodeling factors in the microenvironment are picking up these lesions. But of course, for the future, if we want to even continue the search for better and better markers, the goal, the ideal would be to have completely specific, tumor-specific markers. But this panel is performing much better compared to the FIT. And so, in fact, it's capturing something that the hemoglobin is not capturing by itself. I'm not sure if I'm really answering the question, but yeah, it's a little bit of a speculation. What could be the reason why these proteins are detecting better adenomas?
Graeme, you want to comment on this?
Yeah. Yes. Look, thanks, Beatriz and Veerle. You've pretty much answered my question with regard to the pathogenesis, because I was wondering about the relationship to the bleeding phenotype, which is what FIT detects. And so, and whether or not you were, it might be that they were tumor specific. I knew that calprotectin wasn't, but I wasn't sure about the other protein. There's two historical comments. At my age, I guess you have lots of history to report on, but it's actually 30 odd years ago now since we were initially looking at calprotectin as a marker, and with adenomas in the colon, there was a surprising amount of calprotectin signal, but it was so non-specific that people didn't actually proceed with it. And more than 30 years ago, we actually set up panels of monoclonal antibodies against feces and looked at cancer versus non-cancer patients to find the most prominent proteins. And the three highest prevalence monoclonals were haptoglobin. So we were still detecting the bleeding phenotype that way. And so it would be of interest, but not, I mean, you've obviously picked the best ones in a predictive sense, but I wonder how many of the other markers that were there that might have been informative are also related to the bleeding phenotype.
Yeah, we see indeed that the bleeding is still the strong marker. That's what we see also in practice when we were doing this regression analysis. But yeah, they do complement a little bit each other, so they can increase a little bit on the value of the FIT. And yeah, and still it remains, although our goal was to look for tumor-specific proteins, we ended up with not completely specific. It's not that they are not having a role, because of course these proteins, they all have multiple roles, but it's really not a classic epithelial tumor specific proteins what we get as best performer. So it's still a challenge, yeah.
Manon, might I ask both of them another question? It relates to the presentations. Is that okay? Veerle, I sent a question to you that you've obviously looked at, and that was this: the whole issue with these tests is what value do you pick when you start to go forward from the initial discovery? And there's actually quite a lot of debate going on about that now. For example, the companies that are producing these tests with major panels of biomarkers and so on, ctDNA tests and so on, are really looking at a variety of different techniques. And traditionally, we've used this approach where we've taken several cohorts and we've sort of looked at the data and we've done an ROC analysis and we've picked the best point, and then we've gone out into a real population and we fiddled with that best point. But the approach that some groups are taking now is taking a reference population and actually identifying, say, the 95% or 98% percentile in a non-affected population, and then working off that value going forward into the intended use population. And when you were talking, I was wondering whether you'd use that approach or not. Now, you mentioned in your response that you hadn't, but I wonder whether you had a view on that approach. When you're starting to work out what the criterion value should be, this issue of setting the value first from a normal population to control specificity and then moving from then forwards.
Yeah, that was indeed the approach we took. Well, actually, in the discovery phase, we also experimented with other statistical models. So, of course, when you want to maximize predictive value of a marker combination, also the modeling approach may play a role, because some modeling approaches simply facilitate the interaction between markers better and also more easily incorporate nonlinear effects. And we saw that this was possible in the CART, classification and regression tree approach. But there's also a disadvantage of this approach, and that is indeed that you do not get a continuous outcome like when you have a linear predictor from a logistic regression model. So then you could easily tune using an ROC curve, and here you basically have you have a limited number of choices actually, and a limited number of possible cutoff points. And among those that were possible, we selected, so we minimized classification error, tailoring to a 95% specificity. So if you want my view on that approach, I think it is a challenge, and we do not really know yet how we can tune it very well. Of course, you can also tune the different cutoffs for the different markers. And that is what we will need to do if we want to tailor to another specificity or to a positivity rate in the screening population.
Yeah, thank you.
Yeah.
Okay, so moving on to the Q&A section, Callum, I noticed, has made some really helpful comments in the Q&A box. I don't think there's any specific questions, but Callum, correct me if I'm wrong, and I'll ask them. So Callum has stated that in relation to Hermann and Tim's talk, that more women have undetectable fecal hemoglobin than men, and more young people than old. But the main point is that to gain 50% positivity would require a fit with a very low limit of detection and preferably very low limit of quantification. And it's also important to note that the analytical performance characteristics which impact outcomes are usually less good at low fecal hemoglobin concentrations. So Hermann, I don't know if you want to comment on that or acknowledge.
Yes, thank you very much for this comment. That is absolutely right. Of course, to be able to use a fit with 50% positivity rate, you have to have a fit that has a low limit of detection. Actually, there are, as you know, big differences in the fits that are offered. Actually, we looked at this in our large colonoscopy screening cohorts where we had done this comparison of 9 different quantitative fits that Carlo actually briefly mentioned in his talk. And from these 9 fits, some of them could simply not be used because of a too high limit of detection, but for those that had sufficiently low numbers or low limits of detection, we could derive actually the sensitivity and specificity to detect various kinds of adenomas, non-advanced adenomas, advanced adenomas, and colorectal cancer. And we used those sensitivities and specificities for our modeling. And of course, for application of this approach in population-based screening, one would have to work with a test that has a sufficiently low limit of detection. Regarding the diagnostic or the test characteristics, we simply worked with the sensitivities and specificities that were obtained with all the uncertainties of how good these test characteristics or these analytical characteristics are. And with all these uncertainties, still the results, the overall results on the performance were as good as we got them in the model.
Thank you, Hermann. So the next question is from Finlay McRae, saying multiple markers seems to be the way to go, HB, DNA, protein, bacterial, but how do you limit deterioration in specificity when you add more targets to improve sensitivity? Might there be mathematical ways to combine the results so that adding markers can be done without adversely affecting specificity? Does anyone want to comment on this? Beatriz?
I can comment. Well, maybe Veerle wants to comment also, but it was indeed one of our worries was to add a lot of markers and then reduce the specificity. And that's why when we did the comparison, we wanted to fix at a high specificity what would be then the performance of the marker. So we would like to increase sensitivity, but with a note that we shouldn't go down in specificity. Veerle, you want to add something?
Yeah, I agree on that. If you include multiple markers, of course, you will have to come up with a statistical method that allows you to tailor to high specificity regions. Otherwise, that risk of losing specificity is very large.
Yeah, can I just comment on that too? Actually, I'm going to say more or less what you just said, I think, Veerle. I have seen some approaches with very large panels where instead of picking the panels that gave high sensitivities, they ignored those. They picked the markers that gave very high specificities and just a little bit of sensitivity, and then put those together. The problem is if they are based on the same biology, you don't actually compound the sensitivity. So you have to have the fancy algorithms. And of course, in some sense, those of us who want to have a flexible and adjustable endpoint for the test, we don't want algorithms that you can't adjust, because that means we can't adjust the test accuracy to suit our screening program. So that's the other thing that we're going to be asking as people develop the test technologies using the panels and using the algorithms, that there's some transparency in the algorithm so that it can be tweaked.
Yes, if I can comment, I think that this point about the possible correlation between different biomarkers, which are markers of the same biology or the same kind of lesion, is important, because it should be elucidated before going to combine these biomarkers together. Another option is also the fact that you could use biomarkers in a sequential approach, like a triage test. For example, in the gate opener approach, you might introduce some intermediate biomarker to select those people who are at higher risk of lesion, and to select people for colonoscopy if you have, for example, not enough colonoscopy capacity to match a 50% positivity rate. These are different options to use combination of biomarkers. But then, of course, modeling and algorithm are probably the way to go if enough transparency can be achieved to combine these.
Okay.
I guess what could I just add one thing? What I experienced while fitting these models and trying different types of models, and of course this was only with protein markers, so maybe it would be better to combine different types of markers. But my experience is that it is actually incredibly challenging to keep high specificity and optimize sensitivity under that constraint. And I think that's why we are quite happy with a relatively maybe small increase in sensitivity for advanced adenomas, because we've realized how difficult it is to improve. There's probably more clever algorithms, but if you include many markers also, your test will become really very expensive. If you and that's so it's really trying to find a test that's actually affordable, not including too many markers to test, because then that will increase the expenses of the cost. I think it's a very challenging area.
And perhaps I can comment a bit. Actually, we compare the different biomarkers from stool samples. We start the methylation DNA markers, and based on the stool samples, we also did the microRNA biomarkers from stool samples. The microRNA biomarkers got the Chinese FDA approval and for the whole country practice in clinical practice right now. So we also established about bacteria or microbiome biomarker, and based on the stool samples, we have an overall comparison. We have to consider the cost, stability, and also we have to consider about the simplified procedure of the detection. So the microRNA biomarker is a quantitative PCR-based assay, and the bacterial biomarker is also a PCR-based assay. A PCR-based assay is very cheap. I think it's less than $10 US for the detection. And in terms of the microRNA biomarker or bacterial biomarker, I think it's better. The good advantage as compared with FIT, they can detect the early stage of advanced adenoma or early stage colorectal cancer. This is a big advantage, and based on the microRNA detection or bacterial detection, and just based on the simple quantitative PCR assay. So it's very cheap, very convenient, and the sample is very stable. And that's why at this moment, we just compare with the methylation DNA, and then also the DNA mutation. We did not working on the protein part. So it's very interesting. I just learned from today, and the protein part is very interesting, the potential biomarker for colorectal cancer. So we're working on the methylation, mutation, microRNA, and bacteria, and perhaps from our point of view, the microRNA and the bacterial marker are potentially quick and efficient and less costly. So right now, and the kit in Hong Kong for bacterial marker is already applied for clinical practice. One is in mainland China, one is in Hong Kong, and also the nearby country. So this might concern in terms of the stool-based detection on different kind of biomarker. We're working on the stool-based biomarker for about 20 years. So we have accumulated stool samples in the fridge and the freezer, and the -80 freezer, a lot of stool samples, accumulated stool samples, focus on different kind of comparison, and aim to identify the best panel of this biomarker for CRC or adenoma detection.
Thank you, everyone, for such a great discussion on that. I have one quick comment or question, and I know it's something that came up in Beatriz and Veerle's talk, that you were using 2 different fit methods, and it kind of all links into what we're talking about. So you have the fob gold that you were using for the fit and the OC sensor for the MT fit. Could you do both on one? And I guess it links into the work that Jun Yu is doing as well, because in an ideal world, to keep costs down, if possible, you'd use a single sample for all the different tests.
I can answer that. Well, we were also aiming to do that because we discovered we validated our protein markers in leftover fit. At the moment, because we have biobank cells from historical collections, and before the screening program started, all the pilot studies were done using OC sensor. That's why in our biobank we had OC sensors. So when we started developing the antibody-based assay, we used the samples that we had that were leftovers from OC sensor. So the antibodies that were, or the assay that is now optimized for the study was fine-tuned using the buffer from OC sensor. And of course, our goal was to use the FOB gold, to use only 1 tube in the study. But at the present, the assays that were now developed, they don't really work in the buffer of the FOB gold. So it's just a practical issue. But of course, in the next step, when we go for a final test, antibody-based assay, we have to start again this development using other buffers. And of course, our objective would be to using the same leftover material to detect the empty fit. But it was a practical reason why we used the OC sensor, because it was the biobank that we had available at the moment.
Yeah, great. I thought it would be that. It's just something I think that if we keep trying to get everything on the single fit, whichever fit it might be. So I'll just pick up another question. So Patrick Bosuit asked a question, and then we got the answer. I think it might be quite helpful to pick it up. So in our experiences for Veerle, in our experience, CART does not always offer the best performing classifier. Have you evaluated other ML methods, such as a gradient boosting method using all proteins measured?
Yeah, so we have used different approaches, but not very many. We have used logistic regression as well, and we've used rich regression, and we actually have not found a better classifier than the one that we obtained with CART. In general, I think that other methods. This links also with the question that comes later. I think there might be a promise in other statistical techniques and maybe other machine learning or artificial intelligence techniques. But the disadvantage is that you include many different markers. You could, for example, also use random forests maybe, then you make many card trees. But the problem is then we would have used all the protein markers, and we specifically aimed for a test with a small panel that would be affordable in the screening program. And I think this is another challenge. So maybe it might be possible to obtain a test with a better sensitivity and high specificity, combining many markers using clever algorithms. But how are we going to contain the costs? And in that sense, having started in the past with a fit-based screening program has raised the expectations, because fit is so cheap and has already made such an impact that you have to compete with a very, very cheap test.
Yeah, thank you, Veerle. If I may, before picking up the next question, just have a question for Graeme with regard to the cost effectiveness, because in your study from Veerle and Beatriz, it was shown that before they start the clinical trial, they first did a cost effectiveness study. So is this also something that is addressed in the consensus process of the guidelines or guiding principles in evaluation of new tests?
Sorry, Manon, I missed a couple of words that you actually said there in the beginning. I think you're asking me about the phased process and something about a particular stage, but I missed a couple of words because of the internet.
Yeah, sorry. Is it addressed in the consensus guidelines or the consensus report that we first have to do a cost effectiveness study before starting the clinical study of a new test?
Okay. The short answer is no, because I'm of the view that cost effectiveness studies are very speculative if you haven't got some data from the real world intended use population. I mean, we know what things need to go into models, but you can do your preliminary limited cohort studies to get a rough idea of sensitivity and specificity. You have no idea what your participation rate is going to be with that test unless it's a sample that's equivalent to existing ones at the moment. So the modelling, in my view, is pretty crude in those first couple of states, and the most effective, I think the most useful cost effectiveness is going to come as you start to move to the intended use population. So cost effectiveness is definitely a required outcome from the perspective at some point in the process. And I think that this comes to a point that I glossed over in some degree in my talk, that it's really a question of who are we providing the evidence about these new tests for? Who are we trying to prove them to? Okay. And we would say, as screening enthusiasts, we want to know that they're going to reduce incidence and or mortality. Okay. We know that that's a really long shot and a lot of work. So we look at the intermediate endpoints. If you look at professional guidelines, they're going to have the same approach. They're really going to say, we want to have some security that that's going to be the case. But regulatory approvals don't require that sort of high standard. In other words, their regulatory approval processes are not so much looking at cost effectiveness as the professional guidelines are, and the healthcare providers have to spend the money. So the issue of when does cost effectiveness become important is really dependent on who you're gathering the evidence for, who you want to convince.
Maybe I just, oh, sorry.
Yeah. Go ahead, Beatriz.
Can I just add something? Because indeed, what we did was, like Veerle mentioned, was an exploratory health technology assessment. But one thing I would like to emphasize is that the retrospective validation that we did was already in prospectively collected samples that came from a screening, from an intent to use population. So it was a screening population, the COCOS population that we had in the Netherlands. And that's one thing that I think it is in the guidelines, that emphasizes the need to have really proper biobanked samples from intent to use population, because even if you are still in the phase of retrospective validation, then you are still already testing your new test on an intended use population. The only thing you cannot test there, of course, is compliance and etc. That will come in the next phase. But for exploratory HTA analysis, maybe that's an important aspect, that also the retrospective validation should already be as much as possible in the target population.
Yeah, thank you. I mean, my comments were not inconsistent with what you did. It was really, you know, setting the broader scene, and those your points need to be explicit as we redo the guidelines. So you'll have to watch.
Okay, so we still have two.
Veerle had a point.
Yeah, I just wanted to add that cost effectiveness analysis is often seen as a late stage analysis, which is done just before regulatory approval and before large scale implementation. But I think there is a place for cost effectiveness analysis much earlier on in the process, even as industries are developing new tests. And of course, then it's context specific. What might be a good test for the Netherlands is not for US. And in the US, for example, the Colorectal is a nice example. I think it has improved sensitivities, but it is hugely expensive. And this might be an option in the United States, but in the Netherlands, this would never be considered. Also because of logistical problems, of course, as a good screening test in our program. So I think if the aim is to improve a screening program and you want to make a test targeted to that area or context, then I think an early cost effectiveness can guide you. Then you know, for example, we were guided by the principle it has to be cheap, it has to be affordable, so not too many markers. It has to be in the fit current screening program logistics. So I think there is a role. That's my main point.
Yeah, Veerle, and this is also what Gerrit Meijer is emphasizing in his comment on the Q&A, in putting the early health technology assessment in test development, so that much research efforts and budgets are spent in a futile way on developing assays that never would be able to make it to the clinical based on a negative level cost effectiveness that could have been predicted at an early stage. Okay, sorry, Sally.
No, I was going to say exactly what you picked up, Manon. Teamwork. So we do have a couple of questions or a couple of comments. So Callum Fraser has thanked Carlo for his presentation. It's important to note that some of the statements made about how much better fit are than FOB are dependent on thresholds used. Certainly in the UK, we have high thresholds being used, but fit have so many advantages, including uptake, cancer detection rate, adenoma detection rate, etc., even at these high thresholds. So that's a comment from Callum. And then Stephen Halloran has commented on the stability of markers prior to collection and analysis, and I would hope that is considered as part of the evaluation of methods. And if any, I don't know if any of the speakers want to comment.
Maybe I can comment on that. That the approach. Sorry, can I make? If I make a comment, that was exactly also one of our starting points, was to look at the biobank samples, stool samples that were already in the freezer, and we thought if we can detect there the proteins that are already with they survived the gut, they are already in the freezer, but if they are still robust enough to be detected, then they are the robust markers that we want to proceed with. So we didn't come from a tissue-based discovery and then let's see how it performs in the stool. We started immediately with the tough material, and if the markers will be robust enough, then we could continue with them. So that would say a lot about the stability of the proteins or the markers that we want to use.
Great.
Yes, and with respect to Callum's comment about the cutoff, of course, there is an issue of the cutoff you are using in the programs, which is related, of course, to the capacity to match the endoscopy the resources, and the cutoff you should use for evaluation purposes. Of course, the interval cancer rate is increasing if you are using a very high cutoff. But when you are using FIT as a standard, probably you should use a low cutoff or a low positivity rate to be able to explore which is the performance of the test over a wide range of positivity rates, so that you can then decide which is the affordable capacity in terms of colonoscopy and affordable interval cancer rate, because in some way interval cancer rate is the result of the decision about the cutoff you are going to use. And so you can decide to afford a certain rate of interval cancer based on to balance between this downside effect and the fact that you can maintain the sustainability of your program, offering the test to the entire population based on colonoscopy capacity you can have. So that's clear that when you are using FIT as a comparator, you should set at some point a reference positivity rate for starting the comparison, and then you can adapt when you are implementing in your program the new test based on a simulated performance at different positivity rates that you can derive from the analysis, the comparative analysis.
Thanks, Carlo. So we have 2 minutes left. There's one question we haven't managed to pick up, I'm sorry, Stephen, about AI, but definitely something I'm sure that's been considered around the world, artificial intelligence. And then Graeme has one comment that he would like to make. Have about a minute or two, Graeme, if that's okay, to finish off.
Okay. Yeah, look, thanks very much. I have a few more questions, but I can email people directly to deal with them. I think that relaunching this process of looking again at the guidelines is going to be a very interesting process, and it's far more difficult than it was when we actually started this process, in fact in 2008 when it was started. And the presentations that we had earlier this year and today have really highlighted the issues and the challenges that we face. So I can't name the 47 panelists who are involved in the consensus process. Some of them are here, but they've been very helpful, and that is not yet complete. We've still got to work through some more fine tuning there, which is going to be very, very important. So firstly, I wanted to thank the panelists and I wanted to thank the speakers. I do need to make a point that one of my slides, somehow the recording got messed up, and that was the slide that was looking at the documentation of analytical performance characteristics and having those effectively, it was a principle where those performance characteristics needed to be bedded down. There needed to be careful documentation. The researchers needed to follow those documentations. They needed to be validated for doing the test. So the quality issues are not just around colonoscopy and so on, but they're very much around the test. And as we hear today about the microbiome and we hear about the fecal proteins and so on, these are much more complex technologies than doing a FIT test. So it's quite crucial. The principle that we had on this point got a very high score for consensus, but the clinical biochemists came in with so many comments that I had to completely rewrite the statement to actually get it right. And as I listen today, I'm still not quite sure that it's right. So this is an ongoing process, and I just wanted to thank you. And Manon and Sally, I think it was a great idea for us to join with the FIT group to have this chat. So thank you very much.
Thank you, Graeme. Also, I think it was a really nice session, and I hope everybody did enjoy it. I did. I want to thank all the speakers. I want to thank my co-chairs and chairs and Enka and Alexandra for helping to organize this session. But before we'll close the session, just to remember that the 25th of November, there is a webinar about the polyp detection, characterization, resection, and AI. A webinar of the WEO, so November the 25th at 6 p.m. I wish you all a good day. I hope you did enjoy it, and hope to see you next time. Thank you all.